Yeah. Jen sir, will start?
Yes, sir. Please start
Okay.
the session, sir.
Okay. So first of all, I'd like to thank ASAMI India President, Secretary, Jen sir, and Amar sir, and other ASAMI officials for inviting for this Friday webinar. And today we have the expert panelists are Dr. Vasudevan sir, Prasad sir, and Mangal sir, and Milind sir, and Cherian sir also is there. So I'll be starting with my lecture, that is bond defect management. So as you know, bond defect management requires multidisciplinary approach and it focuses on restoring mechanical stability and biological healing. And the treatment depends on various factors like soft tissue defect, bone defect, infection status, etc. So we'll be discussing these factors in this lectures. And I'll be discussing under these settings, that is basics of bond defect, classification, management, and algorithm of treatment. So when we start discussing bond defect management, so the first question arises in our mind is, what is the minimum bond defect which heals without any bone grafting or any other procedure? That's the first question. So in order to understand this, we should know what is the critical bond defect. The critical bond defect is one that will not heal spontaneously despite surgical stabilization and requires further surgical intervention, such as bone grafting. There are a lot of studies conducted to find out the precise size and volume of bone fitting this criteria. And none of these studies could define properly. And this is the one study, that is a sprint study in, they have conducted 1,125 patients of tibial fractures. Only 37 patients, that is 3% of these patients, had a critical bone defect defined as greater than 1 centimeter in length and more than 50% of the cortical diameter. Of these 37 patients, 47%, that is almost 50%, has achieved union without additional treatment. So that suggests critical site defect may not be truly critical, and that depends on so many other factors. So when you want to decide about this, you should consider other factors also before you start treatment. This another study by Ains et al. He coined the term, that is radiographic apparent bone gap, RABG. That is, he measures average bone loss of all 4 cortices. So how to find this average? So suppose this here you can see the picture, the medial cortex is at 20 mm is lost, and other cortices is escaped. So here 20 divided by 4, that is a 5 mm is the RABG. The second scenario, you can see the medial cortex and the posterior cortex, 10 mm and 20 mm. So the 30 mm divided by 4, that is 7.5 mm is the RABG. So if RABG is less than 25, union rate is 50%. And if RABG is more than 25, union rate will be 0. So these are the inference from all these above studies. And bone gaps size should not be used in isolation to make clinical decisions. Multiple factors from anatomical, biomechanical, and biological prosthetic all play a role in predicting non-union. And anatomical location of the defect has a significant impact on healing potential. So if you compare the femur and tibial defect, femur defect has favorable soft tissue environment and spontaneous healing reported in segmental defects measuring as much as 6 to 15 centimeter length. And if you compare with the tibia, it has got relatively poor outcomes and lack of spontaneous healing in segments of bone loss as low as 1 centimeter with greater than 50% of the cortical circumferences. So coming to the defect causes, you can have the various causes: post-traumatic, post-infection, neoplastic, and miscellaneous like congenital, CPT, etc. So whatever the cause, the defect management is almost similar. And what are the types of bone loss? So you have the 3 types: evident bone loss, potential bone loss, and unrecognized bone loss. Evident bone loss means extrusion fragment at the time of injury, that is evident. And potential bone loss means during debridement of an open fracture when deviated segments of bone are removed, thereby creating the defect. And unrecognized, even after debridement, sometimes you may keep some fragment without knowing that it is lost the blood supply, and that can later defect a defect. So coming to the classification system of bond defect management, this was published in Jeejesh 2005, and they consider three factors, that is bond defect, soft tissue defect, and host type. Bond defect again subdivided into type 1 to 4 depends on the size of the defect, that is less than 20 millimeter to 20 to 60 and 60 to 120 and more than 120. And soft tissue type defect divided into alpha, beta, and gamma. Alpha means no soft tissue defects, no soft tissue reconstruction is required, and beta means soft tissue defect present on request or soft tissue reconstruction. And gamma means unable to reconstruct soft tissue defect. And host type again divided into ABC, as you all of you know, it's a modified McPherson. And type A means good immune system and delivery, and type B means compromised locally and systemically, and type C means immunocompromised. So when you want to come into the management of the bond defect, so it has to start from patient optimization to soft tissue defect, then comes the bond defect management. So first thing is always patient optimization, second is soft tissue management, then only comes the bond defect management. So we'll discuss each one separately. Patient optimization means you find out the risk factors and you address it properly. Basically convert the type B to convert the type B host to a type A host. Then soft tissue defect management here, alpha, beta, gamma defects are there. Alpha means envelope has no current or potential future soft tissue defect. Beta means present the soft tissue defect or the bony reconstruction procedure will result in soft tissue defect. Gamma means not amenable to reconstructive surgery. So here basically soft tissue management to convert the gamma or beta to an alpha wound. And the plastic surgeon form an integral part of limb reconstruction when soft tissue defect are there. And they have the reconstruct ladder introduced in 1982, that is starting from healing by secondary intention to a free flap. And as an orthopedic surgeon, we have 4 potential strategies you should know, that is how to treat the bone defect or soft tissue defect. These are the 4 methods. You can acute or gradual limb shortening. So basically convert the beta wound to an alpha, a deformity assisted wound closure, or open bone transport, or negative pressure wound, that is VAC therapy. So all these methods are, you should know as an orthopedic surgeon. And these are the example. Acute shortening and lengthening means here is a soft tissue defect and a loss of pylon fracture. You can say bone defect is there. So here you can do an acute shortening and lengthening at different sites. So this was treated with the Lizaro. And you can see the debrided, make it transverse, and gradual acute locking was done up to 4 centimeters, then gradual locking was done. And finally, just a vac was applied, and finally just a small skin grafting was enough in this case. Otherwise he may end up with a rotation flap, free flap, etc. So there is no plastic help actually. And it was, you can see, and you can do a lengthening at different sites so that limb lengthening limb length you can maintain. So this case was after the union, you can see how he is walking. And deformity assisted wound closure. That is, here also we have to convert the beta wound and alpha. You can keep it in a deformed position. Sometimes you have to keep an equinus or calcaneus position if the wound is in the angle or in the any varus or valgus if it's in the tibia. So basically to heal the wound, allow the wound to heal, then you can later correct the bone deformity or the bone defect. Then open, of course, if the wound is so big and gamma, and you can do an open bone transport. The negative pressure wound therapy, you can see this is a case of the elbow, almost sidestep injury, and it was debrided and it was treated with the SSC after VAC application. Then transport was done. So coming to the bone defect management, there are various surgical techniques as described. That is, one is the induced membrane technique, that's otherwise known as masculine. Then vascularized fibrillar allograft and bone transport with Elizar or LRS. Then fibrillar transport to the tibial defect. Acute limb shortening and lengthening by Elizar or LRS. Then interlocking nails directly, or you can use transport or lengthening over nail. Then you have the cage or mesh. Then intramedullary lengthening devices. Example is a precise nail. Then newer technique like plate assisted bone segment transport and 3-dimensional bioprinting. So we'll discuss each one separately. Masculine technique, all of you will be knowing it is 2-stage procedure. First stage, you have to debride it, and Siemens spacer you have to fill in, and so that pseudo synovial membrane forms, which prevents the bone graft absorption. So after 6 to 8 weeks, then remove the spacer and you can do a cancellous graft. And but the advantage is the time of bone healing is independent of the length of frequency. That is the advantage of the masculine technique. But there are a lot of drawbacks for resistant to torsional shear or bending stress. Need to be fixed with the internal or external fixation for stabilization. Then it's a two-stage procedure and limited autograft. Suppose that it is a big bone, so a big defect, you may not get all the autograft from this patient itself. Then you have the vascularized fibular graft. There are three types: vascularized fibular flap, a sole bone replacement for humeral defects, or vascularized fibular flap combined with an allograft and tibial defect, or vascularized double-barrel fibula, especially in femoral defect. And the advantages are better healing and improved strength, and can be harvested as a composite flap, or can be folded in 2 or 3 for additional strength, can be used in metafacial or diaphaseal region. Then the drawbacks are microsurgical skills and equipment needed. A well-vascularized bed is needed. Prolonged operative times, risk of failure of vascular anastomosis, mismatch in size when used in lower limb. And in case of failure, not only the recipient, but also the donor site also is compromised. That's another drawback of this. And there are a lot of complications also described in donor side, that is transient peroneal palsy, compartment syndrome, stress fracture of the ipsilateral tibia, risk of failure of the vascular anastomosis. Then flexor hallucis longus cutter and valgus deformity of the, especially in children later, valgus deformity develops an ankle motion weakness, etc. This is a method, another method is a fibular transport. This was case of type 3 C fracture. It was open fracture. It was stabilized with debridement stabilized with external fixator. You can see the bad soft tissue. And this was done by Vasudevan sir. I took it from his permission. And here you can see he treated this case with this fibular transport, and it was stabilized with Ilizaro, and it was well united. You can see here, and alignment is also very good. And so another method is a tibialization of the fibula, especially it was done in children.
कुठे आलाय फोन? अच्छा.
Hello. So tibialization of fibula. So here you can see it was done in childhood. The patient is 35-year-old. Now patient has a deformity and shortening developed. So these are one of the drawbacks of this stabilization of the fibula. Another method is the cage, and it's available as either titanium cage or biodegradable materials are available. It is indicated in tumor excision, post-traumatic defects. But the advantage is it's a single-stage surgical procedure you can do, and is suitable for patients that will not tolerate multiple surgical procedures. And drawback of this cage is a limited autograft required, especially when in very young children, and sufficient bone quality and anatomy to apply supplemental fixation is needed. An aseptic wound with a healthy soft tissue envelope is needed. And another method is the interlocking nails you can use for the bone defect management, and it is minimally invasive, can be used in conjunction with Elizaro or LRS for lengthening or transport or anything you can use. And it allows relatively early weight bearing. And the drawback of this ILN bone defect management is not applicable for all metaphysical defect, not suitable for forearm, humerus, and sometimes in tibia. And this is one example. It was type 3 open fracture, debridement, and external fixation was done. Bone defect. You can see here up to 7 to 8 centimeter bone defect is there. And once the wound was healed, the ILN was done here, and it was the transport of the bone over nail was done here, and it was united in around 5 to 5.5 to 6 months. And this is, you can see the docking was done once it is reached there. And the nail was and the frame was removed after 1 month of 1 unit. And here you can see the X-ray, post-op X-ray after removal of the ring. It was well united. This is its function. And of course, the Elizara method is the choice for all the types of the bone defect. You can do bone transport, acute locking, and lengthening. Also, anything you want to do with LRS or Elizara, we can do it. And this is one example where you can see it was a failure following the limb salvage surgery. It was a GCT, and and salvage surgery was done. It was infected, debrided multiple times, and finally the implant was taken out. And now this was a situation. And here it was treated in stage wise, and intramedullary antibiotic nailing was done, debrided. Then after that, once the wound was healed, the stabilization with the Ilizaro, and the bone transport was done from here down to upwards. As and proximally there is a bone cement also both sides. So even you can see the distal also I could not remove the rim, but it's still you can see the regenerative quality is good even if the cement is there all. So this is after 8 months it's united and the frame was removed, and this is a very old X-ray, so quality is poor, and the patient is walked comfortably and it was removed. And another example, similar case, but here the GCT was in the femur, lower femur. Again, it was a limb salvage surgery, and they tried to orthodosis with a fibula graft, but that also failed with an infection. And here, after infection control, we did the Ilizaro application. And here you can see the instead of transport, and here it did a gradual acute and gradual docking of the at the knee joint level, and the lengthening was done distally. So same type of cases, but differently managed. And you can see the strong union at the knee and at the lengthening site also. Another method is intramedullary lengthening devices or precise nail. I don't have experience with this. And here intramedullary lengthening can be done using this. Lower risk of infection, reduced pain, improved aesthetics and psychological well-being of the patient. These are the advantages of precise nail, but some drawbacks are limited biomechanical strength and durability. In case of mechanical failure, surgical removal is necessitated. Implant is not reversible, and proper measuring is needed before implantation. That is all about the soft tissue and bone defect management. So I will discuss a algorithm of treatment for this bone defect and soft tissue defect. And this was published in January 2021 in Strategies in Trauma and Limb Reconstruction, based on the same classification which we discussed earlier. And basically, you have the soft tissue type on one side and bone defect types and host category. Suppose the patient is having alpha soft tissue defect and host type is A, and if it is the bone defect is less than 2 centimeter, then primary bone grafting with internal fixation is sufficient for this type of cases. If it is 2 to 6 centimeter, these are the options. First choice is musculate with the primary internal fixation, and non-vascularized graft or Ilizarov fixator is the 3 different choices here. And if it is 6 to 12 and the first choice is Ilizarov fixator, then you have the musculate or fibrillar graft. If it is more than, again, the Ilizarov fixator, or you can use vascularized fibrillar graft or musculate technique with internal fixation. If it is a type B host, then if it is a less than 2 centimeter, instead of primary bone grafting with internal fixation, you can do a shortening here. And rest all 3, you can do an Ilizarov fixator is the treatment of choice. So alpha type patients, this is the algorithm for our treatment. And suppose the patient is a beta type of soft tissue defect and type A host personality, then if it is less than 2 centimeter, you can do acute shortening for the wound coverage. Then you can apply internal or external fixation, depends on your choice, and then you can do a musculate technique. Or 2 to 6 centimeter means musculate technique or bone transport or open bone transport with Ilizaro. If it is 6 to 12 centimeter, bone transport through induced membrane or musculine technique. If it is more than 12 centimeter, you can use a vascularized fibrillar graft in the upper limbs and bone transport through the induced membrane. And type B host, if it is less than 2 centimeter, acute shortening for wound coverage, and preferably with Ilizaro, you can use here in type B. If it is in type A, and you can do either internal or external fixator. Then 2 to 6 centimeter bone loss, you can use open bone transport, Ilizaro bone transport through the induced membrane. And 6 to 12, again the same choice, open bone transport, Ilizaro on bone transport, induced membrane. And you can, if it is more than 12, beta and type B host, open bone transport, Ilizaro. And if it is failure, then you can consider amputation, especially in case of type B host and type C host. And in gamma type of wound, the main aim of this gamma wound is to convert the gamma wound in alpha or beta wound stepwise. So by means of external fixator application, once the wound is healed, we can go for the definitive fixation. So here gamma wound, basically first we have to convert the wound to an beta or alpha wound. And you can consider amputation, especially in type C or type B with more than 12 centimeter and be host. So the message is primary aim in open fractures with bone defect, no, not the maintenance of length, not the partial or pseudo dependent. Regaining length is easy. Can do at least at later stages. Obtaining union is the problem, and short heel bone is the victory. And thank you. Hello.
Yes, sir.
Yeah, it's over now.
Yes, sir. You just have to stop sharing your screen if you want
Yeah.
to. Sir.
So I would like to invite for the discussion, followed by the case discussion will be Dr. Krishna Kumar, Dr. Arun Lal, Dr. Subramanya Gandhi, and Rama Kartheek, and followed by a case for opinion by Dr. Akansha. So first we'll discuss. Vasu sir.
Now the case presentation is happening, no?
Before that, we'll have a discussion followed by the case presentation. 10 minutes for the discussion, followed by we'll have the case discussion.
So there's a question in the chat box actually.
Ah.
Is there an upper limit to the length of bone defect that can be covered by bone transport? Or is there any reason to think not to think about bone transport for defects more than 15 centimeters by Dr. Udit Biswal?
Yeah, if it is more than 12 to 15 centimeter, you can do it, but better would be you can gradual or acute docking for few centimeter, then you can do the remaining length, you can do a later lengthening, bone transport followed by lengthening. And depends on the soft tissue status also, we have to consider whether we get other options also. So it's a multifactorial. So not only the just defect, it is the soft tissue status, infection status, and multiple factors has to be count.
Actually, I have a case of bone transport with a loss of about 23 centimeters. And then I have done a carticectomy, dual carticectomy, one above and one below, and convergent type of bone transport has been carried out. But that was initially it was B-type, gradually converted to with skin grafting, flap cover, and everything. By the time he came to me, it was almost sinus free and no bone is exposed. Everything has been done. He came in a splint and can be done even if it is long, but you have to consider doing it double or triple osteotomies. That is the way it can be managed.
Double level osteotomy to such
Yeah.
cases also.
Yeah.
And do you have any faced any problem during transport, such a long standing 50 centimeter?
Yeah, 11 centimeters on one side and 12 centimeters on the other side. Even though he is a bit tall, my problem was at the time of docking. By the time they have come nearby, the docking edges will become round because of the soft tissue pressure. And I have to do a pressing of the edges, rounded edges. Otherwise, they were trying to slip away. But very difficult to do because the transport segments were only about 1.5 to 3 to 4 centimeters long. That's all. So the gap between these two is very much less, and I have to negotiate the saw and do it in a very difficult situation. That is one problem I have faced in that.
Another problem in long transport is the skin invagination. So in long standing, skin will be, so the transporting fragment will protrude through this. So how you, sir, Vasudevan sir, and any other senior faculty can
Anyhow, we have to freshen the edges. At that time, we will open that up and then elevate the skin, and do the freshening, and do the darking.
Okay. And suppose it is protruding through the skin, so again, we have to stop the.
You are increasing the complications.
So that is another possibility. Usually that happens.
Yeah, true.
So
They will be
how
in two different levels. In a single level, they will be in a two different levels. One may be anterior and one may be
that
posterior,
is another
something
way.
like that. And docking problems will be there, and difficult to manage that skin also if they are in a different levels.
So okay.
But once it is open, and once we reduce them to the opposing surfaces, then the skin will, I think, that will come into a near coverage.
Okay. Vasu sir and Mangal sir.
All these are part of the game, no?
Yeah.
Yeah.
And one case I want to highlight is Vasu sir, that fibular transport, no? How you attain that? Is it a gradual one or
It's a gradual one.
gradual one? So he transported from lateral to medial gradually.
Yeah, along the
So
intrusion
the
of
problem
border.
with this, so how much time it will take to get it hypertrophied in such cases? How many years you will follow up for the
It
bracing
takes
and all?
nearly about an year.
So that will get hypertrophied during 1 year is sufficient.
Yeah.
So such cases have you
And
ever faced?
in between, some people can develop a stress fracture of the fibula.
Stretch fracture, yes, that is one thing.
That's one that very common. But again, you don't have to worry about it. You can just give them a support, and with the POP itself, they can manage it.
Okay.
And
I'll give a little different point of view for that. I've done vascularized fibulae for these large gaps.
Okay.
And I have not really seen a hypertrophy which I would be confident to leave that patient without a brace even at 2 years. But still, because that side, the fibula itself is intact. So now there are two thin columns. That is, one is the healed fibula, and the other is the vascularized fibula. So then we are still a little confident. Now, so when we talk of moving the ipsilateral fibula, I have a little bit of a worry in terms of how safe that will be at the end of 1 year to weight bear, free without a brace.
Okay.
even the long term, they have to be on a brace.
That's my point.
And the other issue is in the microvascular fibula, how do they stabilize it with a plate? How do they do? They do only screws.
No. What we use the fibula as a intramedullary we put it into the canal proximally and distally.
And put a ring fixator.
And put a ring fixator. Yes.
Ring fixator, yeah.
How long they will? How many months you'll keep the frame on?
Frame is probably on for about, on an average, I would say around 4 months, 5 months, which is what it takes for the proximal
Union.
and distal ends to heal.
Yes.
And then they are converted to a brace initially above knee.
Yeah.
And then once.
I think I had a few patients where the fibula is fractured, but even then you just give me a walking PTB cast.
Correct.
Maybe initially a long leg, a short above knee cast. It heals in about 6 weeks time.
Vascularized fibula also, stress fractures occur. And I say that getting a stress fracture is a good thing because it leads immediately it leads to thickening of the fibula.
Yeah.
Sir, along with the Mangal sir, along with the vascularized fibula graft, do you do bone grafting also? Cancel bone grafting also?
No, because it's intramedullary, no. So no need to do grafting.
Okay.
I'll ask in one of the future meetings, I'll ask my fellows to show those cases.
And sir, in children, suppose a bone defect, I have shown one X-ray where in childhood they have done the tibialization of fibula, but later it results in a shortening and varus deformity. So do you recommend such cases, tibialization of fibula or bone transport?
Jeejesh, the case which you have shown, they done tibialization of the fibula only at one end. The other end, they have not done the tibialization. It has to be on both sides.
But yeah, both end you have to means.
Yeah, you have to do both ends. That is not being done.
So it is resulting now the varus deformity. So
And now the problem is they didn't do the distal tibiofibular union. So most probably they must have stopped it.
okay,
We should do on both sides.
both sides.
Yeah.
So in such pediatric cases, better to do Lizaro bone transport, no, or you have to do
All
both
sides.
sides, sir.
You can do fibula directly for them.
So both sides you have to stabilize.
Yeah, both sides you have to do it. But I do only slowly so that there is you can see in that X-ray itself, there is a linear bone, a graft which is connecting, a linear track of bone from the parent mother fibula to the transferred fibula.
Okay.
So you can see that line.
Yeah, it's there in
It is still maintaining the vascularity.
Mangal sir, what about your precise nail? You are done, no? Precise nail. What is your experience on that?
In management of bone defect.
Yeah, in management of bone defect, have you done?
No, I have not done it. I have not got a patient. Yeah, technically, it could be done.
Yes.
But I haven't had a patient who could afford that for a bone transport as yet. We've had only patients who, for cosmetic lengthening, they are able to afford. Bone transport, they are already drained. So, but when we get Indian nails, ultimately, I think that will be a possibility.
Okay, then thank you, sir.
They have these nails available.
Okay. So shall we stop here and we'll move on to the case?
Yeah, go on
discussion?
to case.
So first of all, I would like to invite Dr. Krishna Kumar.
Manga, your profile picture is very nice.
Who's mine?
Yeah.
Good evening. Jeejesh called me and asked to present a case. And when I asked him, most of the cases that are routinely done was taken by others. So he gave me a difficult situation. He put me in a difficult situation. So I'm presenting a case which was done in 2011, where a 22-year-old gentleman came with a 3-year-old fracture of the tibia. It was an open fracture and which was operated multiple times. So that is his X-ray, and those are the clinical pictures. He had bony as well as soft tissue procedures. This was his initial picture, the first fracture picture, which was treated by an AO external fixator and later converted to an LRS. And you can see that the middle clamp is actually one pin is on the proximal fragment and one pin is on the distal fragment. And after some time, that clamp was removed, and you can see that there is a fracture lower down also. So now the distal middle fragment got necrosed, and that was removed. So right now the problem list is he has a non-union with a gap, but he doesn't have any pain and he is able to bear weight. There is a lateral thrust on walking. There is a little bit of shortening, varus and cross union. There is cross union on the proximal as well as the distal end. If you watch closely, you can see that there is a cross union here in the lower third as well as on the head of the fibula. Also, there is union between the head of the fibula and the tibia. So that's the gait pattern. He was walking without any pain, but there is a definite thrust while he walks, and there is a varus on the right side. And in order to improve his gait, he uses a wooden scale on the medial side of the leg and he ties it with a cream bandage. Now, this was the plan to do a fibular osteotomy, make the bone ends transverse, then use a ring fixator and do a bone transport. So that was an my early days of doing Elizaro, just 3 years after completing my fellowship show. So we had a fellows group at that time and we still have it. So posted the case in that and was waiting for a reply. And this was the reply that I received: to read this paper and reassess the patient. Can a Trendelenburg sign be positive if the hip is normal? Vasu sir's paper. And that is how we reassessed. He had a Trendelenburg sign positive, and when he uses stick on the same side, the difficulty in walking increases. And when he uses the other way around, then he puts the stick on the other side, the opposite side, he's walking without much difficulty and the gait is improving. So that means he has a relative abductor insufficiency. So now we revise the problem list, and these are his 2 main issues. One is varus and the second one is shortening. So now we change the plan. We plan to realign the fibula, and backup plan was always, if it fails, do a bone transport. Because when you're doing a bone transport, we have to we have to make the bone ends transverse. Then we have to transport probably from the proximal and the distal ends and do a docking. So it's going to be a long procedure. So that was in TROP. After correcting the alignment, we used an LRS to do the alignment correction, and this is how we did it. We put the LRS on the tibia and straightened out the fibula. And you can see that the axis is passing through the center. It would have been a little bit more towards the lateral side. But you can see that the distal fragment is a little bit translated. So that a fine tuning was done, was taken into the OT again. And under sedation, the pins were loosened and pushed inside, so that a little bit more of a lateral translation and correction of axis was achieved. And that is at the time of frame removal, the fibula is very well healed. And you can see that the fibula actually is very much hypertrophied also. And he got a freedom from that wooden scale. And this is how his walks after the surgical procedure was, after the fixator was removed. So the learning outcome is proper assessment. You have to find out what actually the patient requires and what is the patient's need and what is the exact situation. And the problems need to be assessed, and whenever required, take a second opinion and revise your problem list before getting into the management part. A little bit of self-audit. It's a little under-corrected. I would have made it a little bit more better. And in the present day, if I am getting such a case, what I would do differently is I might use a ring fixator and a 6-axis device so that I get more of a perfect correction. Thank you.
So this happens especially in children when they have gap non-unions in the tibia. The fibula starts taking most of the weight, it hypertrophies. And then basically the issue is of correcting the relationship of the ankle to the knee. And in these cases, just correcting the fibula, I think works quite well, where generally my goal would be to get the foot plantigrade to the ground. And then, when you do that, your axis is also corrected. So especially for children, this sort of thought process works pretty well. And the tibia stays as it is, the fibula becomes the main weight-bearing bone of the body.
KK, how about the limb-length disparity?
There is still a shortening of around less than a centimeter, because once the deformity was corrected, his part of his shortening was corrected.
Okay.
But still, you can see that in the gait, there is a little bit of a short limb gait.
Right. Is there any possibility of lengthening that fibula?
So that is what, if the situation happens now, I might have used a ring and lengthened it a little bit.
With the LRS itself, you can lengthen it, no?
I was too inexperienced at that time to do
At that
heroics.
time, yeah.
That is a possibility.
And the other possibility is better is the enemy of good.
Yeah.
If no more questions,
Good case.
good case. We'll move on to next
Since
presentation.
the fibula is on the lateral side of the midline, still they run a chance of stress fracture. As KK said, little extra valgus would have been, maybe 4 degrees of valgus would have been better.
No, but Vasu, when we see this in children, they have been walking on that fibula for years in a varus position.
Yeah.
And if anything, the fibula hypertrophies hugely. You
Yeah.
hardly ever, maybe there is microscopic stress fractures and healing going on, which is
Yeah.
what causes that, apparent hypertrophy.
Yeah.
But you hardly ever get a patient. I'm sure you have seen, just as I have, these 17, 18-year-olds with gap non-union of the tibia, but who are walking with the foot in sort of varus,
Yeah.
So that is a question that we have to think about, that stress fracture does not happen in those situations. So probably in this guy also, since his fibula, the tibiofibular joint basically is gone now. It has
No, but-
become a osseous union.
Yeah.
And he had a cross union, I think, of the lower tibia to the fibula.
Yeah. The proximal is but at the fibula head level.
Yes.
That's why if you can shift it like 2 to 4 degrees of valgus, probably that will make it more mechanical laterally.
Yeah, possible.
Okay. So we'll move on to the next speaker. I'd like to invite Rama Kartheek for his talk.
Sir, okay, sir. Can I share, sir?
Yes.
Sorry.
Karthik, you are looking different now.
Sir,
Your head has shaved like mine.
copying, sir.
So Mangal sir, there are a lot of questions in the chat box. We'll discuss it later after this talk.
Sir, can you see this, sir?
Yeah.
Visible. Yeah.
Okay, ma'am.
You can click on play, sir.
Yes, ma'am. Yeah. 18 years old female came with the chief complaint of pain right thigh since 12 years. She has history of osteomyelitis when she is 6 years, and she has undergone suturation for 2 times. She has more pain during night time. This is her X-ray at the time of arrival, and this is her MRI that has suggested of sequestrum. And so I thought of proceeding with suturation as well as the biopsy to confirm the diagnosis and culture sensitivity. Then, when the biopsy was confirmed with the sequestrum and the bug was identified as Staphylococcus aureus, then I'm in dilemma whether to proceed with fixator, which type of fixator, either LRS, IL0 or alpha fixator. IL0 in 18 years old female, distracting at the medial side, she may feel difficulty and she may need help of her father also. So because of that thought process, and she is from a low socioeconomic status female, and she should sit down. So I felt that alpha fixator is better for her, and corticotomy after the infection is subsided. This is her post sequestrum, and sequestrectomy was done and applied alpha fixator. Defect of 13 centimeter was observed, and this is the universal long bone defect classification. It is femur and femur 3, diaphysis 2 segment. Segmental bone loss is type C, and no bone contact, that is in, group 3. So it is 3 to C3. My plan was docking. Meanwhile, while the time of during the time of soft tissue to heal with the infection, I have thought of docking between the clamp 2 and 3. And when the infection has subsided, or the docking when the infection signs or ESR and CRP has become normal, I thought of going for doing corticotomy between the clamp 1 and 2. I have done gradual docking at the distal end to decrease the dead space and increase the contact period between the clamp 2 and 3, the bone, and so that the bone will contact for a longer period, and gradual corticotomy and gradual destruction in the lateral rate. Then docking as well as corticotomy was done at a single stage. Gradual destruction was done. This is after the both limb lengths have become equal. To decrease the fixator period, I have removed the fixator, and after 1 week or 10 days after pinhole day, I planned for plating. This is this is a deviation after 10 days. So I am in dilemma whether to keep anti-grade plating or retrograde plating. When I've measured the plate and all, I felt that distal femur plate, opposite femur distal femur plate is ideal for this case in a retrograde manner, in an antigrade manner, and proceed with MIPO plating in MIPO, sir. This is after MIPO, 3 months after. This is 2 months after MIPO, and this is 5 months after the plating. This is her axis. And fixator index, it is 439 days, that is 3.2 days fixator index per millimeter, 27.3 days for a centimeter, 27.3 days for consolidation index. And this is her functional outcome, sir. Take-home points: alpha fixator is a stable fixator where distraction can be learned by the patient in a little time or no time. Less chances of pin-induced stiffness due to fixator if the perfect safe zones are followed. As constructive stable, less chance of pin-tech infections if pin care is taken. Add plating after pinhole day will produce exuberant callus as the bridge mode, and during the time of fixator, as the region it is a little disturbed after a few days after. Thank you, sir.
Why did you excise all of that bone? What was her problem?
Sir, that is due to the pain. That is pain, sir. This is sequestrum, sir, and it was confirmed with biopsy, sir.
No, sequestrum, yes, but where was that sequestrum? Intramedullary.
From here to here, sir.
No, sure, we are not seeing that. Just put it on presentation again.
Okay, sir. Can you see, sir?
No, put it on presentation mode, na?
Oh, sir. Okay.
Yeah.
Sir?
Yeah. Okay. So then why did you excise it?
Sir, the reason for the pain is due to that sequestrum, sir.
No, I understand. So this is you have taken out, and then when did you do the excision of that middle segment? Okay.
I have waited for 2 weeks. I have waited for 2 weeks, sir. If her symptoms are subsided or not, as well as the cultural sensitivity and the biopsy confirmation of the biopsy, sir.
Okay.
Then I have nibbled till I get the bleeding, sir.
No, but after this, her pain didn't settle.
It is settled. After this, pain is not settled, and the discharge has started, sir. After this procedure.
Okay. Just go back to.
It doesn't look like sequestrum, no?
Go back
Just
to
the previous
MRI,
image,
sir.
Dr. Rama Kartheek.
Go back to the intact this thing.
It looks like a
Intact schema.
cyst, like this thing, not looking like a sequestrum.
Is it an osteoderm or something like that? Pain?
No, just go back to the full femur. Yeah. Okay. Now, Why is this not an osteoid osteoma number 1?
Sir, osteoid osteoma, it should be usually it gets it will be it resolves within 3 to 4 years, I think, sir. Pain, and it's not responding even and it was confirmed with MRI even. She has a history of osteomyelitis at her age of 6 years.
What does the MRI say?
So it is highest of sequestrum, irregular symmetrical cortical thickening, distal half of the metaphyseal diaphyseal right femur, irregular asymmetrical cortical thickening, medullary sclerosis, heterogeneous hyperintense signal involving metadiaphyseal region, distal third of right femur.
But where is the sequestrum in this?
Sir,
No, in the report, see the report. It's reading there.
Sir, highest of
The cloaca projecting planes or distal diaphyseal region of the proximal right femur suggestive of a sequestrum. Small curvy linear. I think, personally, I think this is more of a intramedullary kind of infection and
the biopsy, this is the histopath report, sir. That I have after suturation, 7x4x3 centimeters bone was received, and features consistent with bone tissue sequestrum.
What you have removed is not sequestrum, no?
That what I have removed biopsy, that I have given for biopsy is sequestrum, sir. That is the histopath report I have given at the right side.
That much bone you have removed is sequestrum. That is not something that I will agree with.
Okay, sir.
In the sense
Was
that
there purulent pus discharge inside?
Sorry, sir. Sorry.
what did you find pus and granulation?
From the medulla, I have got it, sir. The bone is too sclerosed, sir.
Hello?
Sir, hello. Am I audible, sir?
Yes, you are audible.
Yeah, bone is sclerosed, sir.
We've lost him, I think. Rama Kartheek.
Sir, am I audible, sir?
Pankaj sir is audible.
Sir, hello.
Hello.
Yeah, Ram.
Sir.
Sir, that part which you are seeing, the sequestrum is a dead bone.
Yes, sir.
And dead sclerotic bone.
Yes, sir.
Sclerotic bone itself is not a sequestrum.
Yes, sir.
The dead bone, that is the one which you have removed is the involucrum which is around.
Sir, the bone doesn't seems to be like an like what you say, newborn, sir, and I can't even drill over that that bone, sir.
Okay.
It is highly sclerosed, sir. And after I thought in the same process, if it get reduced after suturation and local antibiotic.
Sclerosing of Gary.
Sir.
Hello.
Sir.
Mangal sir, his connection is lost or no?
I think Mangal has lost it.
So
it may be a sclerosing osteomyelitis of Gary.
Yes, sir. Can be, but pain, nocturnal pain since some 12 years, sir.
No, the pain is because you are not stabilized, no?
No, sir. Before this, at the time of presentation, sir.
No, that is because intramedullary pain.
Sir.
They will have intramedullary tension is more. I think that you can safely debride that area, clear it out, and will fill it with stimulant or something. That would have been more than enough.
I would have probably looked at this more in detail in terms of CT scan, etc. And think of an intramedullary infection, ream it out as required, probably not even, saucerization would be limited in terms of if there is a sinus or something like that. You ream this out and place a local antibiotic into that. Even something like stimulant now has those bullets which are there.
Yes, sir.
That would save you a lot of time. I mean, you have treated her and you have sort of sorted out her problem, but at a risk of having all kinds of other issues. Now, you are experienced with Elizarov, and therefore, if there is a problem, you can sort of get away from it and all that. But this is not something that I would necessarily recommend excising so much bone just for that pain. This would need to be looked at more in detail in terms of where is that pain coming from, what is the cause, and then accordingly treated. And I would say that this could possibly have been treated by, dealing with intramedullary infection, because all that sclerosis that you see around in that region, in that initial X-ray,
Sir.
is the body laying down more bone to kind of wall off that infection.
Sir.
So,
Right.
yes, you have got it success.
If at all you are planning to find out a sequestrum, will
Sir.
you like MRI or a CT?
I would like to proceed with CT, sir.
CT was not done in this case?
It was done, sir. It is not with me right now. Sir, she has done more doctor shopping. She has many reports. I think I don't have her MRI with me right now.
See, you see this, the medullary canal there in the center is sclerosed.
I too had a similar case,
Sir.
a young girl, where I think I just opened it, chiseled it out, and cleared, as Mangal said, put stimulant there and put a titanium plate. Minimally put a titanium plate without touching that area. Spanned it.
So this picture to me is more suggestive of an intramedullary focus rather than onto one side. And here is the body trying to wall it off, and as Vasu pointed out, it could be intramedullary tension which is causing the pain. And did I hear you say nocturnal pain?
Yes, sir.
So nocturnal pain is classic for osteoidostoma.
Osteoidostoma.
Not only, I suppose there are many pathologies which end up with nocturnal pain.
Even with the infections also, no, sir?
It's not necessary that nocturnal pain only comes from osteoidostoma.
No, but
so many
classically it is
pathologies.
osteoidostoma.
If you have tuberculosis
The first
of a
thing that
joint,
comes
the
to
pain is
mind
more
is
at night. So it's not, night pain is not characteristic of osteoidostoma alone. And the osteoidostoma diagnosis is confirmed only with a DSA. Complete confirmation comes with digital subtraction angiography. So you have a biopsy report on this, Karthik?
Yes, sir.
What does the biopsy say?
Sequestrum. Here, the right upper one.
So what, you solved the problem now? It's the patient is free from pain, is the gap is filled up and everything?
Yeah, everything. She's jumping, dancing, skipping. The problem is solved. What we
So
heard.
congratulations are in order. Let's move on. Let's give him
Yes.
a box of sweets and all of us enjoy the rest of the evening. There's a Japan-Turkey match going on.
So-
put in a plate also.
No, just to ask something, the sequestrum, if it was a sequestrum that was already removed, and is that the bone cement there?
Sir?
What did you
Wasn't
fill
the
it
bone
with?
cement inside?
Immediately after removing the sequestrum, sir?
Yeah.
Yeah.
No, sir.
What is filled in there? There's some
Here, sir.
material there, no, in that gap.
Here it is PM bone cement, sir. After suturation, it was bone cement. Now,
So
after
that-
complete sequestrectomy, I haven't done.
No, the discharge that you got, somebody
Sir.
has pointed out in the
Yes,
chat. The discharge might be because of that filling also, right?
But the discharge has disappeared after complete sequestrectomy, sir.
Hello?
You removed
With the sequestrum, you
cement
remove the
also
cement
along
also, no, Raja?
Yes, sir. I do agree.
So All right. Let's get the
Anyway,
chat questions, finish them, and then go to the next case.
yeah. So, yeah,
I'm on a phone. Someone will have to read those chat questions.
yeah. So the first question is, can you please explain more about open bone transport? What about regenerate in open wounds? From Dr. Himanshu.
Open bone transport.
Yeah.
I don't know what does he mean by open bone transport?
Means, sir, means gamma type of wound without soft tissue coverage, we can do directly apply the Irizarro and we can do osteotomy and lengthening. So gradually what happens is this wound will
That
get
wound
healed.
contracts.
Yes, sir. Yeah.
The wound contracts.
Contracts and it will be healed by secondary intention and coverage of the fibrous tissue. So that is basically the open bone transport where very difficult to manage the soft tissue, gamma type of wound. So that is the open bone transport.
Okay.
Their transport is not open, no?
Transport is not open. It is we are doing.
Opening is open docking.
Pardon?
It's open docking.
No, sir. Open. No. Open bone transport means in such cases.
Transport area is not open.
Transport area is not means the corticotomy site is not open.
Yes.
What you're doing is basically bringing the two bone ends together, and as you bring the two bone ends together, the soft tissue travels with it. That's what.
Yes. That heals the wound.
Next question.
What option is there, sir, for infected revision TKR after implant removal? The defect would be 12-15 centimeter, 12 to 15 centimeter, and some wound defect. What are the options for knee arthrosis in such conditions?
One, send the patient back to the TKR surgeon. That's the first option and the best option.
Good.
Because otherwise they never know what they are doing.
So nowadays, a lot of infected TKR end up with arthrosis knee.
Yeah.
No, yeah, so that's one major lesson we have to learn.
I don't bother to lengthen and get only union.
Yeah.
Yeah. So LRS is the one option we have. Mangal sir is learned from Mangal sir.
I don't think, no. Let me tell you that I think LRS is not as good an option as the Ilizarov. I've used the LRS for sake of convenience.
Okay.
I don't, today, if I had to do something, I would do, I mean, I do Ilizarov and not the LRS because LRS has got many limitations. One is femur and tibia have to be in one straight line. So that makes it kind of a little bit of a varus. You can't make it into a neutral axis. It becomes automatically this thing. And if the pins start loosening and all, you have trouble. Whereas with the Ilizarov, it's much easier.
Yeah.
So today I would say that, especially if you're starting off, stay away from the monolateral fixators. A ring fixator is probably the best.
Will you do a corticotomy for that?
No. I usually go mainly for compression.
Yeah.
But if it's a 12 and I think they said some 12 centimeter gap, then you may have to treat it like a bone gap.
Yes.
But for the normal one with 4 or 5 centimeters, I don't bother about restoring length in those cases. I focus more on the healing.
Yeah,
because that in itself, in these older patients, ice cream cone, all of those things are a problem.
So even if you want the lengthening, I prefer later.
Okay.
Yeah.
So you can do a arthrodesis at the knee by gradual or acute compression, and you can lengthen at tibia or femur, depends on after the union.
Yes.
Okay.
That's what Vasu said later.
Yes, sir. Yeah. So another question.
Dr. Jeejesh, can I speak?
Yes, sir.
Yeah. So I got the message about this webinar 2 minutes before it started. So sorry, I'm joining in late.
Okay.
But on this question of arthrodesis and infected TKR, we've created a new kind of compromise wherein we have got LRS as well as Ilizarov. What we do is we put two 5/8 rings just above and below the knee.
Okay.
And at the upper level, unless the patient is very obese. But even then, at the upper level, we use the LRS and combine it with the LRS and 5/8 ring above the knee and 5/8 ring and LRS below the knee. What that does is it allows the patient's leg to completely rest on the bed and have the comfort, convenience, and have enough stability. Can you hear?
Yeah, please.
Yeah. And I have found that it's not so much of a problem getting. I want to know the experience of other people, but I can tell you that arthrodesis after post-infected TKR takes too long to heal. And it's so easy. It takes 5 minutes to add a corticotomy. What it does is it improves the chances of union. And then at the, some patients have been told of mine, never go for lengthening. So I remember a patient who came and he's ended up with a 7-8 centimeters because he said that one big shot surgeon said never do lengthening in arthrodesis. It's so easy to add lengthening. It makes their life so easy. You just keep them 2 centimeters short to enable them to walk a little easily. It's not a big deal to do lengthening. Karna hai to karo. It's simple. Nothing difficult about it. And it helps them. Keeping them even 4-5 centimeters short is a lot. As it is, the arthrodesis is going to contribute to excessive stresses on the other joints. And then you're adding this element of shortening, which is going to add problems on their spine and force them to use a large raise. Anyway, that's my take. But
Okay.
in general, I have found that the arthrodesis takes too long to heal. What's the experience of, the rest of you?
Same. I was thinking about suggesting to these guys that we have a webinar on arthrodesis of the knee, and then 4 or 5 of us who are doing it regularly present cases and present our problems.
Yes.
Because that is always a hassle with those ice cream cones and all that. It's not and that's one of the reasons why I personally don't want to add one more source for trouble if I'm having already issues with the healing and this patient is elderly and all of that.
That I agree.
Point about shortening is taken, but the way most of them are happy using a shoe raise, which should obviate some of the problems. But yes, that point is what I tend to do personally is, yes, if they want lengthening, it can be done at a later date.
Okay.
In all my fusion cases, I take the femoral condyle, that posterior part and all, take it as a bone graft and put it into the defect.
Yeah, but the cases which I have been doing recently, there is no femoral condyle.
Yeah.
There is a trumpet above and a trumpet below, and when you compress it, one edge of the trumpet will contact another edge of the trumpet, and that also not 360 degrees. It will be more on the lateral side, more slightly on the posterior side, and that. So now when I do arthrodesis, I always tell them it will take 2 operations. One operation to get rid of the infection and second operation to get it healed, at which time we do a bone grafting of that.
What do you do with the patella?
Patella is one more option, sir, to keep it in between.
No. I keep the patella, so the patella as well as allograft is put into the diced and put into the defect at a second stage.
Yes. Yeah, second stage. I do it in the stage 1.
So
one of the issues that is being faced recently is, like, most of the patients who are coming after an infected knee are coming with multiple revisions.
Yes.
So there is a significant number of patients who are coming with even a mega processes on it.
Yeah.
With just the proximal half of femur and the distal half of tibia left.
Refer them to the original surgeon.
It's like limb salvage surgery.
In those cases, it's definitely transport is required.
Yes.
Correct.
But this 5, 6, 7 centimeters, I don't think.
Yeah.
So, sir, shall we
Jeejesh,
stop
more
here?
questions. I can't see the chat.
Sir, can we go on to next speaker? Then we'll discuss further questions.
No, why finish off? No, the chat. The questions are related to previous
Okay.
talks. No, finish them off quickly.
Okay.
And
So,
if any of us talk too much, stop us.
okay. Respected seniors, length of bone transport and docking as a second procedure, is there any relation? From Dr. Ramay.
Ask again.
Length of bone transport and docking as a second procedure, is there any relation?
I mean, I don't think there is a number, but as a broad generalization, the longer the transport, the more the likelihood that you will need to do some open procedure at the docking side.
Yes.
Okay,
But
that sounds.
there's no as a fixed
Yes.
this thing. 3-4 centimeters, you may not need to do an acute procedure for docking. But longer things, then as he pointed out that, you know, the edges get fibrosed or rounded, and then you may need to freshen them up.
Okay.
Next question.
So that's the only question. Rest of the things are already we discussed regarding
Okay, fine.
osteomyelitis.
There is one more, like, do titanium plates really are resistant for infection?
Okay.
That's what the lab says. So if that has been shown that titanium is less liable to biofilm and stuff, and if the cost difference is not too much now with Indian plates available, I don't think there's a big reason to use a stainless steel plate. But yes, it may not be, what happens in vitro may not be the case in vivo. But in the lab, it has been shown that titanium is less favorable for biofilm adherence.
Less doesn't mean no.
Less doesn't mean no. Yes.
I was trying to recollect how many of my so many infected non-union plates are titanium. I don't recollect having only seen SS plates. There's a lot of work underfoot to try and make you know, the more effective. But per se, biofilm is not the only thing that biofilm is one of the things that makes eradication of the infection more difficult. It doesn't necessarily say that unless and until biofilm forms, you cannot have infection. So titanium, no infection in titanium plates is.
No. I think this question was in relation to the fact that the last case, Rama Kartheek did a
Yeah, he put in
transport,
a plate later.
and then he put in a titanium plate. I think the question was in relation to that.
Sir, it's a stainless steel plate.
Okay.
Should you use a titanium plate or will a stainless steel plate do?
Okay.
Of course, titanium plate. Nowadays, most of the non-unions, infected non-unions are titanium plates because everyone uses titanium for fracture fixation.
Yeah.
No, the problem here is now the grandmas and all, they come, they say you have done a stainless steel plate, like I'm not able to take my MRI. So everyone is a fashionable thing to take an MRI.
Correct.
Yeah. Now I stopped using stainless steel because of fear of MRI.
Sir, last time, sir, can I speak, sir?
Yes, Ram.
Sir, last time when I've been to China, the junior consultant of Robert Rosberg has attended to the course along with me, sir. He told that if they want an implant to stabilize the fracture for longer period, they use stainless steel.
Okay.
So
no, I'm not saying the same. I mean, titanium is better than stainless steel. But
So titanium is
you know,
a
some old grandma comes at 89 years saying that you have done one stainless steel implant for me. I am not able to take my MRI.
got it, sir.
Okay.
So that is the only reason.
Okay, sir.
And Karthik, this is very interesting because a lot of implants Synthes is introducing in India only in the stainless steel variety, not in the titanium. So there's something about this.
Now there's a stainless steel, MRI compatible stainless steel is there, no?
Yes, sir. In Merrill company, they have come up with a new combination, sir. So they tell it is MRI compactable, sir. The implants made in Merrill, the plates which they give, it is MRI compactable, but it's made of stainless steel. A different variant of the they tell, sir.
Yeah, it's the stainless steel LVM.
All 316 LVM is MRI compatible. So we've had so many patients who were refused MRI with ABC scan center, and we send them to our guy and he does it. It's not a problem. They don't get pulled out. If your MRI is going to take long, then you can have induced currents and therefore thermal energy and all in that plate. That is one of the issues. It's not that the plate gets pulled out due to magnetic this thing. It is the induced currents which create heating in that plate, and that can cause trouble. But most modern steel has got most modern implants rather, which are 316 LBM. You don't have an issue of MRI incompatibility. It is more ignorance. But who will sit and argue with them all the time? So easier to put in a titanium.
No, sir. The LVM plates, is there a difference between the Tesla, the value of Tesla to be used? That is, some tell that it's more safe in 1.5 Tesla and it's not safe to use in 3 Tesla.
To my knowledge, no, because now the machines that we are sending to the centers that we are sending, they are 3 Tesla. But it could be that, yes, 3 Tesla generates more energy, larger implant, more energy, more heat, that kind of thing. But that's what I'm saying, that in a heat shaft fracture femur, there's not much that's going to happen because with 3 Tesla also, your times are also shorter, no?
Yes, yes.
So maybe that someone can check that up in the literature and then let us know in the next meeting. Let's go to the next case.
Yeah. Next, I would like to invite Subramanya Gandhi for his talk.
So the topic today is on bone defect management. My topic specific is on femur treated by Elizabeth method. So now coming directly onto the case, today's first case, it's a 40-year-old male who presented with a road traffic accident. He had a grade 3C distal femur fracture with the popliteal vessel injury was present. So initially, the first surgery was stage 1 surgery. The patient was taken up for a knee spanning external fixator. So can you hear me, sir?
We can hear you. We lost your screen, sir.
Okay, 1 minute. Now is it visible?
No.
No, not yet.
Visible. Yeah.
Now?
Yeah.
Visible.
Yeah, sorry. So the stage 1 procedure was a knee spanning external fixator was applied with a popliteal artery bypass grafting was done and the fasciotomy was proceeded. Stage 2, after 10 days, the primary surgeon had taken up for external fixator removal and open reduction and internal fixation was done using a long distal femur plate, and SSG cover was given by the plastic surgeon. So hoping that this fracture would ignite, the surgeon waited for a period of around 4 to 6 weeks. Then he felt the initial treatment of stage 2 was not comprehensive. So he went for stage 3, where he did a distal femur grafting with both iliac crest and ipsilateral fibula to fill the entire defect. And he had done a column specific plate fixation of all the 3 columns, lateral, medial, and anterior. And in 1 year, we can see the change that the patient started to develop infection and still the fracture was not united. So this is the presentation at which the patient presented. So at stage 4, all the implants were removed in view of infection and antibiotic spacers was placed. So the problems presented to us at this stage was a bone defect. So for the past 2 to 2.5 years, the patient didn't have any knee movement, so the knee went for stiffness. There was a repaired vascular graft was present. So we can see because of the multiple screws placed in the distal femur is around less than 2 centimeter only is present with multiple drill holes, and we can see an array of avascular bone along with shortening. So the option presented to us with infection with a very small distal fragment, the only option present was Elizaro fixation. So I went in for a 2-stage procedure. First stage was to remove the avascular bone, then to proceed with the Elizaro fixation and the corticotomy and bone transport for the defect. And in stage 2 to do a open docking at the distal site. So on stage 1, we can see once we removed the bone cement, the entire segment was avascularized, which the surgeon had tried to maintain for all the 4 stages to preserve that medial bone, which was leading on to non-union. So the entire segment was resected and the Elizaro frame was applied with 4 Shanspin proximal to the corticotomy and 4 Shanspin distal to the corticotomy. And in the distal fragment, it was done with around 3 olive wires and a single plain wire. So the bone transport was in progress, as we can see here. So in stage 2, once around it came near the distal fragment site, I was little skeptical. Since already the multiple surgeries had been done, I didn't want to go. Since the segment is only around 5 centimeter, I went in for an open bone grafting in this case. I didn't want to take chances further. So open bone grafting was done in the distal femur area in stage 2. And around 6 months post that, we could see a good regenerate proximally. And distally also the fracture had united. So this is around 2 months post frame removal at this stage. So my doubt was in this case was mostly the patient is a very bulky patient, sir. So in this case, we had to use a metal ring, but sometimes with this metal ring, holding the distal fragment is little difficult since the fragment was very small. So we can see in the lateral view, there is a sagittal plane deformity which has occurred. And secondly, this patient is around 250 kilometers away from my place. So around 3 months or 2 months once only I could see this patient, and nearby he take x-rays and keeps on sending. So we had to compromise with around 1.5 centimeter shortening was present in this case. So this is around 2 months post frame removal. Currently the patient is walking. I have advised him to walk with at least the walker for a period of around 3 months. But sometimes he used to walk without this walker also. His knee is completely stiff. And I've told after a period of some time, after 1 year, we can try something. But already we can see in the X-ray that patella is completely fused with the distal femur. So similar case in the second case also, I don't want to go for the second case. It's mainly similar case where plating has been done with the avascular segment and similar resection and bone transport has been done for a defect of around 6 centimeter. So my final takeaway from both the cases will be the initial itself, the surgeon would have accepted that the bone is avascular and he had removed the avascular segments. It would have number of surgeries would have reduced. But since the acceptance was not there, that the fragment was thought as it was still vascular, the number of surgeries and the complaints of the patient was also increased. So to go for initial resection of the avascular segments and to go for transport at the single stage or at the second stage itself would have been a better option from these 2 cases. Thank you.
Yeah, it's good case. So open for
Gandhi,
discussion.
Gandhi, how do you assess avascular bone on day 1?
No, sir, the bones which are already not having a soft tissue cover, which are into bits and pieces, trying to
Yes.
preserve them. already it has come out, but trying to think that the bone, there is not much of option to
Maybe
do bone
without any soft
transport.
tissue attachment.
Sorry, sir.
Without any soft tissue attachment, has to be removed.
Yes, sir.
And the most important point is the gap. We have been told to maintain the length. If you maintain the length, the instability will be more. So your fixation will be weak. Agreed?
Hello?
Hello?
Yeah.
Yes, sir.
Yeah. Then you can deliberately shorten it, say about 1 or 2 centimeters. Get a medial contact
Contact.
rather than putting a medial plate there.
Plate.
Yeah. 1 or 2 centimeters shortening, I will accept it. Getting
That
union
allows
into
the fragments to sort of get together, and it improves your healing.
yes. And getting a
Probably.
union supracondylar area is the priority. And that maintains the knee range of movement. First chance is the best chance.
Was sir, probably getting a little shorter is not a problem, and getting union is you should be a aim.
Yeah, but everyone says you maintain length.
So that
So the point he's making is when you have a grossly comminuted fracture, especially if it is closed, then you don't need to pull it out to length. You can let it collapse a little bit. That leads to a better
Yeah.
Ashish, mute yourself.
Done, sir.
sir,
Maintain the alignment. Little bit shortening is not an issue.
not an issue.
Okay.
And whatever the loose fragment has to be removed. Better to.
Yeah.
This was what grade compound, Gandhi?
Grade 3C, sir. It was a vascular injury also present, sir. Popliteal injury was also there, sir.
Yeah. But in the femur, if you know, if your debridement is good and you have good cover,
It can
of
get
course,
away with it.
yeah, loose pieces, of course, they are not going to contribute. But again, there, if you shorten, then your issue of healing
Vascular
becomes
repair was there, sir.
that much. Yeah, but you can shorten 1-2 centimeters in terms of shortening is good for the vascular repair also.
Yes, sir.
Yes.
Yes, sir. In the initial stage itself, they should have done it. Yes, sir.
There should not
Sir,
be any distraction rather.
Yeah.
Sir, in all your experiences in vascular injuries, can we do how much lengthening any level or any region rate is there, sir? Or can we go in for normal case transport? Can we go in for more than 5-7 centimeters? Transport can also be done without much of a problem in vascular injury cases, sir, where repair has been done.
No, repair done at least 6 weeks earlier, no issues.
Transport, you're not putting any force on the repair, no? Transport, you're just distracting your bone inside. So that should not be a problem.
Yeah.
Dr. Chaudhary.
I have a little interesting observation since my time of my residency. This is 1985, I think. I think you should never use internal fixation after vascular repair. It's a really high energy trauma. And you should tell your friends, acquaintances, always go for X-fix when you're doing a vascular repair, even as a definitive method for, getting union in these fractures. Every time you use an internal fixation, there's an extreme high risk of infection. And very interestingly, one of our, older members, Ajit Patil, he made a big name for himself around Baroda he was called whenever there was a vascular injury they were doing, so much so that he was called to put on an Ilizarov for pure vascular injury. Okay, not just with a bad fracture, because the fixator really stabilizes, the construct of the vascular repair. And obviously, when there is a bad trauma with a vascular injury, it's a must to put on a fixator and never, I mean, spread it in your local, meetings, when you have, and don't let your colleagues get tempted to do internal fixation. I remember a case as way back as 1985, I think. It's really very high incidence of 3C injuries, infection, if you do internal fixation. That's anecdotal. And I think Ajit has written up has a big series on this, very big series on vascular injuries and use of Ilizarov. It's really helpful.
Two things are different from then to now. One is the availability of lock plates, which was not, we didn't have a good form of internal fixation at that time. Today we have a much better form of internal fixation, and range of motion, etc., relatively speaking, with good internal fixation compared to the best external fixation. In case of the femur, I'm talking about distal femur, I think is better. So yes, with 3C, the risk of infection is higher, but at the same time, you've got a better soft tissue cover, etc. So a 3C in the femur, I think, would be a little different from a 3C in the tibia. So this is something that would need to be discussed and argued.
Fair enough about modern implants, but all the 3Cs that I have seen, infected non-unions that have come after vascular injuries have all been treated with internal fixation. And very coincidentally, it's just a big coincidence. Hardly an hour and a half ago, I got a patient who had a vascular repair and was only treated with a X-fix. There is no infection. He's ended up with a horrendous non-union, but no infection. And nobody, fortunately misadventured into putting in an infix on him. So my experience in all the infected non-unions is they've all been treated. So that's my experience.
But then we are dealing with a select subset. No, we see only the infected non-unions. We don't see the guys who go on to heal. Okay.
Agreed. It's a good topic for research, finding out what's happening, outcomes of.
Yeah, meaning like,
yeah,
if that kind of a patient goes to, let's say, Ganga, where they're doing everything right in terms of the debridement and soft tissue cover, etc. There is a clear place for internal fixation. But if you are worried, yes, I agree that just splint it and let somebody else handle it. That's also another way of looking at it. Let everything settle down and then go ahead and deal with the fracture. Right. Next case, Jeejesh.
Yeah. So, yeah, thank you. So, next case, I would like to invite Dr. Arun Lal for his talk.
Yeah. Okay, my slide is visible.
Yes.
Yeah, today my topic is management of segmental humeral defect using titanium mesh cage and biomasculate technique. So this is a 45-year-old male with history of fall from height. He had an open comminuted distal humerus fracture with a loss of around 6 centimeter in the distal third, that is in the metaphyseal diaphyseal junction. And there was intercondylar extension of the fracture. There was ulnar neuropraxia. He had diabetes mellitus, hypertension, CAD, and he was post CABG on clopidogrel. So that was his CT, and those were the traction which were done after induction. So the stage 1 was damage control orthopedics, that is debrided the wound and put a elbow spanning.
One sec. What happened to that bone? Was it extruded or what?
Yeah, it was lost, sir. He didn't come with the bone. It was lost.
Okay, so he came with the fracture.
Yes.
With bone loss.
Yes, sir.
Okay.
So that was the presentation.
Yeah, sure. Okay.
So that was the stage
Where
1.
was the wound?
Wound was on the posterior aspect. That it comes next, sir. So there was a wound. You can see that there was a transverse wound here, And so I debrided it and then put a elbow spanning external fixator. So that was stage 1. And there was contamination in the wound also. So those were the postoperative X-rays following the first stage. Then,
Arun, where did you put that contacts together?
yes, I'm coming to it, sir. So next, the stage 2. So I had to manage this bone defect, and the options available for me were distraction osteogenesis. We can shorten the humerus, cement spacer and masculine technique, followed by cancellous bone graft or fibular graft, or vascularized fibular graft. And I cornered onto this one as the patient was very bulky. I mean, his hand was very bulky there. And also I wanted an antibiotic, local antibiotic delivery in that region also. So my stage 2, I did on day 4. I debrided it again. And the intercondylar fracture was fixed using cannulated cancellous screws. And I placed antibiotic loaded cement spacer in the bone gap. So that was done on stage 4, I mean, day 4. So this was the stage 2 postoperative X-rays. So when to do the second, that means after the cement spacer, when to remove and assess for the membrane, and when to do a cancellous graft after masculine technique. Literature says that the BMP2 expression peaks at 4 weeks marks. Usually we do at 6 weeks, but the BMP2 expression it peaks at 4 weeks. At 6 weeks the membrane develops well, but at 4 weeks it's a little fragile. So you have to be careful while interfering at 4 weeks. So I went in at 4 weeks, and for definitive reconstruction, the external fixator was removed and the cement spacer was removed. Then I harvested corticocancellous bone graft from bilateral iliac crest, and I used a cylindrical titanium cage, packed this graft onto the cage, and buried it inside and then over that, I use a posterior distal humerus LCP, and to enhance the stability of the cage, I used screws through the plate into the mesh also. So that was done at 4 weeks. And those were the postoperative X-rays. And arm sling was given for 2 weeks. Then flexion extension as tolerated. And the staples were removed at 2 weeks, and resistance and strengthening exercises from 2 weeks. So that was the follow-up at 2 years, 6 months. We can see well united distal humerus. So that is his function. He has a stable elbow. And the ulnar nerve neuroplaxia was completely recovered, and there was unrestricted pronation and supination. So this induced membrane, it acts as a biological chamber, and it acts as a barrier that prevents outward diffusion of graft and prevents resorption of the graft. And the cylindrical titanium gauge, it gives a good, it's a load sharing device, and it provides exceptional stability against axial bending and torsional, and it also allows early joint mobilization. And using these two together, there is synergy. There is optimal biomechanics with the biology. So there are possible risks, and how to prevent this? There can be persistent infection. So after 4 weeks, if you feel that the membrane is not looking good or it is healthy, you have to abort the grafting. You have to redebride and place a new antibiotic spacer or change the plan. If there is a device failure or loosening, you can use a locking plates instead of the routine plates. And you have to incorporate the cage into the construct by adding screws into the cage. It adds it adds to the stability. And to prevent donocyte morbidity, like if there is morbidity, if you are using bilateral iliac crest, you can use femur irrigation aspiration, or you can use fibular strut grafts. So my take-home message is debridement is the key factor which decides the outcome in open fractures. Induced membrane acts as a powerful biological chamber. Titanium cage provides immediate mechanical stability there, and a combination is effective for management of bone defects. But we have to be aware of potential risk involved. Thank you.
Well done. Congratulations.
Thank you, sir.
Thank you, Arun.
Thank you, sir.
Open for discussion.
You in that lateral femur plate, you had only 2 screws, or
Sir?
How is the cage stabilized?
how many screws you had in that lateral plate, in the femur, in the humerus plate?
Sir,
2 or 3 screws.
3 screws for the intercondylar region, and for the plates, I have added screws later, sir. You can see that on the lateral view.
Is the
No,
screws
what? Say again.
passing through the cage, that screws? That is stabilized with the 2 screws, no? That's cage, sir.
Cage is stabilized.
Okay.
That's fine. But in the distal fragment,
I had 1, 2, 3, 4 screws on the plate and 3 screws for the intercondylar regions.
only 3 screws. Okay. So what would you say to putting in a bone cement and then doing a bicolumnar plating without the cage?
Without the cage. So this was my initial.
How is the cage superior to a bicolumnar plating?
Yes, sir.
With just bone graft? You already have the masculae and the biological power, etc.
Yes, sir. So the defect was nearly 7 centimeters, sir. So my plan was
Correct.
initially like this. It was a 7 centimeter. I thought the cage will add more stability to the pure cancellous grafter. And we
I understand. So I'm saying that's what I'm saying is your cage compared to a bicolumnar fixation. That is a medial column plate also.
Yes,
Because
sir.
you've got such good bone on the medial side over there,
Yes, sir.
and a couple of screws above in the proximal segment
Yes, sir.
would also give you stability. The reason I'm asking is because we've done a few cases like that without cage,
Yes, sir.
putting in the bone cement
Yes, sir.
and internal fixation, and then going back and doing the grafting. So the bicolumnar fixation is a well-known sort of way of fixing, especially for comminuted fractures and all that. So in the femur, it's been shown. In the humerus, also it's been shown.
Yes, sir.
So you have space there for like in your diagram. You see.
Yes, sir. I saw that.
You have space for really good 3 screws which will hold that fragment.
Yes, sir.
Well, and personally, I think that would hold better. No, you can't argue with success, meaning obviously your system has worked.
Yes, sir.
But I think it is more the biomechanics would be better with a medial plate. That's all.
Yes, sir. I take that, sir.
And the other thing I want to say about the masculae, just go back to your
The point I mean,
bone cement ka this thing.
It has to be done in such a way that
Correct.
it covers the distal distal
Yes.
bone and the this
So
thing.
in this kind of a situation,
I had
especially when the patient has come to you first, it may not be a bad idea if you are confident of your debridement to fix this and then put your cement so that it covers the bone ends, etc., etc., etc. The places where I have failed in terms of masculae have been where the cement is kind of hanging in the air.
In between.
Like that.
Should ideally overlap.
It should. So therefore, fixation becomes useful over there.
Yes,
and you have a good debridement. You've got a good soft tissue cover there, so you can fix it with bone cement.
Yes, sir.
So one more thing I have to
Leaving
add
the
is
bone cement as a
Hello.
Go on.
Sir, one more thing I have to add is the muscular technique proper. When you want to apply the cement in the space, that such cement has to be overhang on the both proximal and distal, and then only the pseudomembrane forms.
That's what we said.
Yeah.
Then the pseudomembrane forms, but you will not get the pseudomembrane over the proximal end and the distal end. That's the point.
Yeah.
That's what we just said actually.
Yeah.
Varush
That's
had
what
there was some question that came up on the chat box.
Varun, if the cage gets infected by any chance, can it be removed easily? Dr. Varush.
Yeah, that's what so I've written here. So there is always a chance for infection. So how to prevent it? I mean, if you think that the membrane is healthy or the infection is persisting, you have to abort.
If you do get
So
but later on, if some infection develops later on after 3 months, it's going to be hell to get that.
you can remove, you can
cage out.
do a bone transport, sir. So cages has been used.
No. You can.
Arun,
Yes.
Cages. How will your bone is forming? How will you cut the cage? You
No, sir.
require a proper.
No. You can resect the bone above and below.
What?
You can do an osteotomy. You can cut the bone just above the cage and below and take out the whole thing as a single construct. And the cage will be loose there. It's already infected.
Arun,
Yes, sir.
Leaving the whole gap
yeah,
again.
I have seen 3 infected cage
Yes, sir.
in the femur.
Yes, sir.
So it was a hell of a trouble to remove it.
Yes, sir.
Because some of the bone which is within the cage has healed, and then the cage acts as a persistent nidus for infection.
Yes, sir.
And bleeds like hell.
Yes, sir.
Require all those bloody rotors and all of that. Or of course, then you take out the bone as you said, but that is again. So that's the point to be kept in mind. Okay, any more? Last case?
Sir, thank you, Arun. One more case for opinion by Dr. Akansha.
So,
Okay.
so my screen's visible, sir?
Yes.
So good evening. Thank you for the opportunity, sir. Wanted to present this 24-year-old male who presented to me with an injury that happened 10 months ago to his right distal femur, which was a compound injury, and a closed injury to the same side tibia. Both of these were managed initially with an external fixation, and now he presented with a sinus. Just a second, sir. Yeah. So this was the clinical picture presented to me, sir. His knee range was very minimal. It was 10 to 30 degrees. And when I asked him to contract his quadriceps, I could only see contraction of the vastus on the lateral side. These are the clinical images, sir, with the x-rays on the side. He also had an injury about 3 years ago to the proximal tibia, which was plated. He had a sinus on the anterolateral aspect, just at the junction of the split skin grafting and the normal skin. So he's got no comorbidities. And when I evaluated him for the tibia, there seems to be some sort of union happening. I looked clinically for an abnormal mobility and I couldn't elicit one. So the workup shows that his CRP is elevated, ESR as well, counts are normal. I wrote down my problem list, sir, and I'd like to share that. So in the femur, there's nil quadriceps spar. There is a nidus of infection as evident by the sinus. There's some sclerotic callus that has bridged the posterior aspect, and the distal fragment is in malrotation. There's significant scar tissue to deal with. The tibia is probably maluniting, and there's metal work proximally to plan for any procedure. So as of now, my plan.
One sec.
Yeah.
Significant sclerotic callus, is that a good thing or a bad thing?
It's a good thing, sir.
Correct. So it's in your problem list.
Yes, sir.
What I see on this X-ray is proximal end of the callus is attached to that proximal femur. Distal end is attached to the distal femur, and the distal femur is in a significant amount of extension.
Yes, sir.
Right.
Which is why I mentioned it in my problem.
Is this a non-union or a union?
Sir, I think it's in non-union to a great extent, because clinically there is an abnormal mobility that's present, sir, in one
Okay.
plane, but not in both planes, sir. Not in only in mediolateral planes it's present.
Okay. Yeah, okay, go on.
In
So,
such cases, you must take a stress view.
sir,
The stress view will show you where exactly the abnormal movement is happening.
okay, sir, I'll get it done, sir.
But what about that distal femur, which looks sclerotic and sequestrated? The whole distal femur below the
Yes,
callus.
yes, sir, this part.
No, above. Distal to the proximal femur. That is sequestrated.
Yes, sir. This part anteriorly and
Yeah.
yes, sir.
So what is your plan now? Go ahead first.
Yes, sir. So, I would like to address the femur first and tibia later. He doesn't have any pain or any tenderness as such at the tibia, which is why I wanted to debride with an anterolateral approach and use the intervening edges to ensure that there's good bleeding and bring about as much alignment as possible on table with an Ilzerov ring fixation. Place hinges and plan for a deft fixer. This was my plan. I would like to know how to proceed with your input, sir.
Where
Why
do you want
Sir, I lost you there, sir.
Where do you want the hinges for the fix?
Why anterolateral?
Sir, actually, I would like to
Go,
expose.
Vasu, you say first.
Vasu sir asked where I would like to place the hinges.
No,
Sir,
why hinges for the fix?
sir, just provisionally, in case the Ilizarov rings do not stay collinear on table, I'd like to hold it with deft fix and then hold it with hinges.
You hold it in the angulated position. You keep just a working hinge.
Yes, sir.
Okay.
So, and sir, I would like to go for an anterolateral incision because this area is extremely friable, to be honest, and I am not very sure as to how well my skin would heal if I would go direct anterior, which is why
No, I said lateral. That's exactly why I said why not go lateral? Because anterolateral means you will be kind of going through this only. No, this is your anterolateral approach. So you will be going at the edge of the skin graft and the skin.
Yes, sir.
So if you go a little more posterior, you will still get access.
Sir.
You have to, debride the sinus and you have to excise that dead bone.
Yes, sir.
That can be done through a lateral approach also, which will,
and probably
I think would, that's what.
The Mangal's approach is a better approach because it allows free drainage out.
Yes, sir.
Free drainage there.
Okay, sir.
Now, I would probably also do a CT to see what is the status of that callus, right? And
Yes.
then I very much doubt that this patient has 10 to 30 degrees of movement with the way that the knee looks. Is that movement occurring at the knee or is it occurring at the non-union? That is one question I would have. So I would do a CT to see how well it is healed to that proximal fragment. And then if the distal fragment is sequestrated, I would take out all, fix the proximal to the distal with an Ilizarov. There may be a gap remaining. If there is a gap, I would probably put in a cement spacer and then use, especially if that healing seems to be reasonably okay, so that then I only have to augment that healing rather than achieve full healing. And at a second stage, I would graft that. Now, the important thing is, if there is no movement at the knee, which is what I suspect, I would have to extend the femur, the fixation beyond those plates,
Sir.
so that the lever arm of the leg is not acting on that non-union side. Because then now, if the femur is stiff, the distal end of the femur and the tibia have become one unit. So if you only fix the distal end of the femur, you are basically fixing a small part of it. You should fix the entire thing.
And
That's how.
That's osteoporotic.
Yeah. So that is how I would deal with that.
I will do a stress view initially before CT, varus valgus flexion extension stress view.
Sir.
So then you can find out where the abnormal movement is.
Sure, sir.
And give methylene blue into that wound on the day of surgery, the night before surgery. So while opening, you know how much bone is the really dead bone. Through the sinus, you can give it.
Yes, sir.
And a posterolateral incision, I'll expose that area, remove it, plan it, realign the hinges depending on the abnormal movement and knee range of movements. Align it, then think about corticotomy only later.
Right, sir.
Align everything well. And always, I would like to span the distal tibial fracture also.
Okay, sir.
Distal tibial fracture also I would like to span.
Right, sir.
Because I want this patient to walk.
Sure, sir.
There was some comment in the chat box. I saw comment.
Yeah, chat talks from Dr. Udit Kumar. Many times in all compound distal femur fractures, we end up with a short distal condylar segment like this with posterior sag. Kindly suggest these tips to reduce such fragments after, say, 3 to 4 months.
One is you put the distal ring in the proper axis in terms of sagittal. I don't know whether I can.
You can draw, sir.
I can. I don't know how. Okay, yeah. So if
Hello.
then if the distal fragment is like that, then your ring should be put in that axis. And then you can use various modes to move that. When you're putting on the ring, to ensure that the that it is appropriate, what you can do is you can put a what is the word they use? A Steinman pin to use as a jack into that size. Into that. What is the word for it here? When we put a Steinman pin and
Joystick.
Toggle it.
Joystick.
Joystick, yeah. Correct. So you can put a Steinman pin in the appropriate angle and then pull this down. But oftentimes, I mean, it depends on what is the status of the knee, basically. If it was a bad compound, infected, fibrosis, it may not move. Then I would just accept whatever maximum I'm getting in terms of correction.
No, if the knee joint is stiff, while correction of that deformity
is not needed.
Knee flexion.
Yeah. But I suspect that what he meant to say was that, you know, you have some mobility over there. So even then, we never get it perfectly straight. Even if there is mobility at the knee,
yeah,
there will be some extension of that fragment.
You need 2 olive wire from behind, possibly with washers.
So, okay.
Yes.
There is angular oblique wire from top to below. 2 washers must be there in the back. 3.5 washers.
Okay,
So
sir.
you put in a wire like this and joystick it down, and then try to get your when you look at your ring in the lateral view, it should be parallel. This damn thing doesn't work only. The ring should be parallel to that axis like that,
Yes, sir.
and not along the tibial axis.
Yes, sir.
All right, I think that answers
sir.
the question.
Yes,
Are
sir.
we done?
Thank you. Sir, thank you. Just one last slide, sir. Jeejesh, sir.
Yeah. Sir, all the senior faculty and was attended here. So our midterm is on August first week, 1st and 2nd. So I would like to all the members to register and ask your other colleagues and other students to register for this. And we have this time midterm ASAMI quiz also. So please ask your members or students to register also, sir.
We have made a very good program. It will be as entertaining as our annual conference. So I think all of us who are doing Elizarov should make these 2 meetings as part of our annual plan. The midterm meeting and the annual conference.
Okay.
Thank you.
Thank you, sir. And I would like to thank our senior faculty, Milind sir, Mangal sir, Vasu sir, Prasad sir, and President and Cherian sir, and President Jain sir, and Secretary Amar Soni, and all the speakers today, Krishna Kumar, Arun Lal, Subramanya Gandhi, and Rama Kartheek, and Akansha, all the members who attend here. Thank you all. And we'll Jain sir too, and Shamsud sir, anything to discuss or talk?
Shamshul, sir, you're on mute. We can't hear you.
Jain sir is there?
No, sir, he left.
Okay.
Hello.
Shamsud sir?
Yeah, you're audible now.
Yeah, so before we end, we have our next Sunday meeting webinar on 5th of July. So I request everybody to send their cases. And after that, we have our next West Zone webinar in August. And Dr. Divya will be moderating the case, the session. So request everybody to send their cases to me for the next Sunday meet.
Okay, thank you. Shall we wind up?
All right. Thank you. Bye-bye.
Thank you so much, sir. Good night.
Okay.
Thank you, sir.
Thank you.
Bye, sir.
Good night.
Thank you,
Thank
sir.
you.
Good night.
Thank you, sir.
Akansha and